Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. And welcome back to the 8 Minute Rule. After a week's break, all these guys are refreshed now with a week off. Got their thoughts rolling well. So our icebreaker today is going to go to Mr. Lucas. And it is going to be, if you could travel to one country next weekend, where would it be and why? That you haven't been to.
I've been this has been high on my list for quite a while, but Turks and Caicos.
Turks and Caicos.
Yeah,
All right. Work on that tan a little bit, right?
it's more about the diving.
Fair enough. All right. So I am excited today because we are going to talk about dosing, specifically regarding exercise. So uh, what I'm interested to get is a take around in physical therapy. There's a nice little spectrum across. Do physical therapists overdose, underdosed? I believe across the board, we believe that there's a sense that we're underdosing a little bit. So I want to get you guys' thoughts on a couple things here as we address the question and kind of look on how can we as clinicians continue to get better in the clinic. So let's start off. I'm going to kick it over to you, Mark. What factors are going to determine how you're going to dose exercise?
I mean, going back to like severity and irritability, that's one of those things that's gonna guide me. But then goal of the exercise. So, what am I trying to accomplish with it? Am I trying to accomplish mobility? If I am, I'm gonna dose it pretty freaking high, and maybe I'm just doing time as opposed to reps entirely. If I'm going for pure strength versus hypertrophy versus power, those are going to have a little bit of different parameters as far as how I'm dosing my exercise. But really, those are kind of the foundational parameters of like at the very basic level of strength and conditioning. When we're getting to that point in time. Now, if we're talking about for pain modulation, it's going to be a little bit different as well. But it all goes back to kind of the goal of what I'm trying to accomplish with my exercise. What does this patient need to recover from whatever they're dealing with? And what do they then need to be able to do? Like, what are their goals? And how am I going to get there? So those are kind of the foundational things that I'm looking at when I'm trying to determine, what dosage do I need to provide for this specific exercise for this patient.
All right, so really digging into severity, irritability is going to be a driver there, and then looking at patient goals. We're trying to develop strength versus power, also including the pain modulation sense. Where are they at? Again, going back to the severity, irritability, really good thoughts there as well. All right, Lucas, is 3 sets of 10 acceptable?
No,
No. Tell me more.
you first need to know, as Mark pointed out, you need to know what severe irritability. You need to know what's the goal of this exercise. You also need to have a standard baseline testing through which you can build your exercise routine, taking in consideration what Mark said, and what you have in hands in terms of the baseline testing you're performing. You may not be able to do 3 sets of 10. You may not be able to do 1 set of 10 with a patient. Even at the lightest resistance of the patient. The other three variables I would add to Mark are load, intensity, depth, range of motion, how much you need to limit in there. And then I will, based on that, based on the goals, based on the irritability, I will determine what amount of reps and sets I'm going to be working with this patient.
All right, so would that number ever be 3 of 10?
You can. It
Okay,
can.
so it can be,
It can be.
but you really want to think through, what allows you to get there. So
Correct.
what would put you in that position?
Circling back to your question, is 3 out of 10 ever acceptable? If you're working hypertrophy, you're gonna be much lower reps with much more load. If you work in endurance, you're gonna be much more reps, much less load. The 3 set of 10 is more of an exception than the rule.
Yeah, I think I can buy that. Drew, you got any thoughts on that?
I do. I think, like you said, there's this idea that we underdose, and so that pendulum, especially like on social media, when you want to get clicks or views, you say these kind of inflammatory things potentially. And I think there's a place where you actually can even underdose purposefully, and it's based on, again, what Mark said, that irritability. Sometimes if there's psychosocial components or the fear avoidance, if there's a lot of that maladaptive pain beliefs and behaviors, and they believe that exercise and movement is harmful to them because they've done this before and it hurts. So if you want to build confidence, I'm purposefully going to be underdosing them early on and then try to build confidence and work on like a progressive overload. So I think it depends on what is your goal and who is that patient in front of you. So it's a lot more nuanced than, hey, we always need to be progressively loading them, and we need to always be focused on building strength because there are a lot of different goals for the individual patient, whether it's pain control or if it is building strength, power, that's going to be different. And even if you're looking at motor control, like you're going to have high repetition because even then I usually don't use numbers because I don't want them counting. I want them to be locked in of like the body mind connection of how does this feel when you're moving? Can you notice when things are off? Are you moving correctly? And so they're not sitting there and just counting to try and get it done. That's where I'll often use time and focus on movement and how they're moving instead of sets and reps.
Yeah, I think that's a really good point. I'm guilty of using 3 sets of 10 sometimes. I'll be the first to admit that. My hope is that it's become more of a, really conveying the point to my patients that I want you to do hard things and I want you to do them well.
Yeah. And I think
And
that can also be a good starting point, and then you move from there because you
yeah,
have to look at the patient's response to that. So
right.
you want to start there? Okay. How was that? You can talk about reps in reserve. How do I want to increase reps? Do I want to change the resistance? But that's not a bad starting point. I just don't get locked in there and stay there forever.
Right. Yeah, I think
Here's
that's a
the
really good point. We want to be seeing how people are doing things. One, as you talked about, how many times in the clinic have you heard and seen people are just trying to get to that mark? Like, it doesn't matter what the number is. I'm going to speed up like crazy to get to whatever number that is to get it over. And really, it's not so much 3 of 10 or 3 of 12 or 5 of 20, right? It's how are they forming it, and is it challenging them? Are we
Yeah.
actually making a change in physiologically here as we're working?
Because a baseline is really good, like Lucas said, but I would say sometimes that's really difficult to get because you're not going to have somebody who's either in a lot of pain or maybe post op necessarily do a 1 rep max. And so you know where they're at. And so use a set of 10 and find out where they are and then go from there.
Love it.
So you use the exercise 3 sets of 10 as a form of a baseline to gauge where you're going. You ask the patient to do 3 sets of 10. Whether they do it or not, it's part of your assessment of it. It's kind of like it gives you a gauge on where to start and where to progress. Is that what you're
I
saying?
would even back it down and just say, hey, do a set of 10 and then let's negotiate like how hard was that? Like what did the form look like through the 10? That way you're not spending so much time doing exercise that may not be appropriately dosed, getting just a baseline, okay, how was 10 reps and then let's adjust these parameters.
That's a good point. Starting with a set of 10 and then varying.
So we're not on a 3 sets of 10. We're on
Yeah.
just a set of 10,
Yeah.
right? So
I,
that's
I,
like, right? The other
yeah,
thing,
I really like that, Mark. I think that's that first set of 10 just being a good baseline. Hey, what does this look like? How do you feel? How's your form? When does it fail? Was it too easy? That really sets you up well. So,
the other
um,
thing Drew said is underdosing. That's something that if you ever took my classes, if you're ever being my mentee, you will hear me saying I rarely, if ever, underdose. It doesn't give me anything. It doesn't give me any
hmm,
answer while a little overdose will give me more answers. But I can definitely see cases where underdosing can get the patient's confidence, trust, and decrease the fear and anxiety um,
Yeah.
better.
That's a good point. And if I have a patient who has some fear avoidance or there's low confidence, preparing them for, hey, you might have some soreness, and that's okay, is also key in that situation. So maybe you underdose or maybe you push them a little bit, but educating them on what to expect and what to do in that scenario, I think is important. And then the other thing is, a lot of times we don't want to have patients come in and are upset because they're really sore because we push them pretty hard. I think there's a the way that I'll typically handle that is if it's muscle soreness and they're coming in for something else because they have joint pain or back pain or something and their muscles are really sore, if you can flip that and you can use it as a look, you were able to push it to the point where you were sore. That's what it means you did a lot more than you've been able to in the past. And it didn't flare up this thing. That can sometimes flip that idea of every time soreness equals bad or pain equals bad. Uh, that's that's the way I'll typically do it. Now, sometimes you do flare them up anyway, which we try not to. But if it's like muscle soreness and it's again soreness and pain aggravating it, I consider slightly different things and letting them
Right.
know
Yeah.
and leading them like, hey, you can push it a little bit. You should be sore some of the time, maybe not all the time, because if you're never sore, you're maybe not pushing it enough, and if you're always sore, you may be doing too much. So finding that sweet spot is key.
Yeah, I think that's key. The language that you can use with it, it's almost not a, hey, I'm intentionally underdosing you, but more, I think the most important thing, as you talked about, when you send them home with home exercise program and they come back, if nothing changed for them, then you underdosed. And it's not necessarily like, hey, I intended to underdose you, but all right, what your body is telling me is it needs more potentially of what we're doing, or we need to shift focus and go a little bit of a different direction too. And so I think even looking at it that way, one takes a lot of the fear out of the exercise activity as well, and kind of gives you a different viewpoint on how you're trying to go about things as well. So cool. All right. Good stuff, guys. I appreciate the conversation here. I think we've got a little bit more on the dosing and it's some good stuff. So if anybody has any questions, fire away. We'll ask the guys and talk a little bit more about it. Until next week.